I'm Susan Grew, and I'm the Programs Director for the Newport Beach Public Library Foundation. And I welcome you tonight. This is the Foundation series, Medicine in Our Backyard. And we are proud to support this wonderful library in their mission to be the cultural, educational, and informational heart of the city of Newport Beach. And as I think many of you know, I see many repeat attendees. This series fits the bill educationally and informationally to a T. We can't put this series on without you. The foundation is completely membership and sponsor supported. We get no outside funding from the city or any government entities. So you're here today, and with your membership support, we are able to put series on like this one. So I thank you, members that are in the audience, and I encourage all of you who are not yet members to please visit our membership table, and you see either our membership application or our beautiful newsletter, which has an application in the middle of it. I encourage you to please take membership applications and join the foundation tonight. With foundation membership comes the special ticket discount and advance notice for all our programs. Our flagship series, the Witty Lecture Series, the names have been announced and they are on our website, and ticket sales are going on, and we're seeing the numbers increase already. So please don't miss out. Take advantage by becoming a member and getting your special ticket discount, and make sure you get your tickets for this wonderful series as well as our other programs. I would like to thank the Kempler family, Dr. Ike Kempler and Ginny Kempler, for sponsoring this series. And I would also like to thank UC Irvine Health for bringing their wonderful doctors here to be our lecturers for this series. This series continues through May. Our next series, we skip December and we'll go January 22nd. And Dr. Leslie Thompson is going to be our new lecturer for this topic, precision medicine and neurodegenerative diseases. And that's on January 22nd, so we will see you then. But before Dr. Thompson, I am very pleased to present tonight Dr. Nimisha Parekh and Dr. Sunhee Park. We are all very lucky that Dr. Parekh did not pursue her initial intent to follow her grandfather's footsteps into ophthalmology, but instead chose gastroenterology so that she could develop long-term relationships with her clients and provide care for chronic diseases. Dr. Parekh is currently the director of the UC Irvine Health Inflammatory Bowel Disease Program. And we welcome Dr. Park. She is a new member of the UC Irvine Health team. She comes from San Diego Medical Center, and we are happy to have her here as part of the UCI team as a gastroenterologist specialist. I now present to you Dr. Park. And Dr. Parekh, too.
Thank you very much for having us. I'm really impressed with the turnout, especially the day after Thanksgiving weekend. So I'd like to give all of you guys a round of applause for your interest in your health, and especially in your colon health. We've been given a big topic today to discuss, and we're going to hit the highlight of certain colon conditions. And then if you have questions at the end, we will answer them to the best of our abilities. And what we're going to do something different in our presentation today. We are going to do a two-part presentation. So today, I'm going to start out and talk a little bit about anatomy and physiology. I'm going to keep it really basic, really simple, and then Dr. Park is going to take over, and we're going to play a quiz game, and you guys are going to be active participants in playing the game, and we have prizes for the top 9 winners. So we do want people to really pay attention, and it's our way of teaching in the kind of style what we call flipped classroom. So it's a way we're going to talk about topics including colon cancer, colon polyps, and then diverticulitis and diverticular disease. And then I'll end the talk with just a traditional talk on irritable bowel syndrome and inflammatory bowel disease. So that's our plan for today. So your colon. It's also known as the large intestine. What does it do? Really, and what is it? So you may have heard different terminology of the colon, different parts of the colon. When we look at our colons, or when we're describing the colon, we look at it anatomically in 5 different parts. So we start from the bottom. We think of the anal canal and the rectum. Then you go up to the sigmoid colon, then the descending colon. Then you go across the transverse colon, down the ascending colon to the cecum, and then that connects into the small intestine. So you can see these numbers are approximate sizes of different portions. They're not exactly hard and fast, but they're approximations of which part of your colon you're in. So for anyone who's ever had a colonoscopy, you may see on your colonoscopy report, oh, I had a polyp in my sigmoid colon. Now you know what part of the colon that means. It's more on the left side, on the lower part. Or I had a polyp in the ascending colon, so that would be on the right side. Or I had inflammation on one side or the other. So that's the anatomy. Now, what is the function of the colon? Really, the main job, 3 main jobs for the colon are to absorb the remainder of the water that's in the waste, and then send that indigestible waste to your rectum, so then you can poop it out. The second function is to act as a storage container. So the rectum is a storage container. So then when you get the urge to go and in a controlled fashion, you can go to the bathroom. There is one other function where certain vitamins are absorbed, or absorption is helped with the colonic bacteria. So really, you need the colon to absorb the remainder of the waste and then act as a storage holder. So there are times when you can live without your colon. Now, on the other hand, your small intestine is vital to life. Just like your heart and your brain are vital, your small intestine is vital to overall living, because this is where all your nutrients that you eat are absorbed. So the main function of the small intestine is to help break down the nutrients, all the food that we eat, break it down into proteins, lipids or fats, and then carbohydrates. It breaks it down, and then it goes through the different absorption. Now, the small intestine is approximately 20 feet. We have 3 different parts of the small intestine: the duodenum, the jejunum, and the ileum. The duodenum is really important because that's where you absorb your iron. So if you have any problems in your duodenum, or inflammation or a disease up there, it can affect iron absorption. The ileum is responsible for B12 absorption. So if there's a problem in the ileum, it can decrease B12 absorption. And then your other nutrients are absorbed in the remainder of parts of the small intestine. I'm breaking this down very simply. It's obviously a very complex physiologic process with the protein breakdowns and the carbohydrate breakdowns. And the main organ, or main little instrument in the small intestine that helps with this, are called the villi. So we have these finger-like projections all over the intestines that help absorb all these nutrients. And so this is vital to life. So there are many times when I'm talking to our patients and they have a condition and they need their colon out, but they're like, I don't want my colon out, I need my colon. And I'm like, you don't need your colon to live. You do need your small intestine, but you can live without a colon. So now we're going to switch gears, and we're going to we're going to do our quiz game. So many people with colon problems, sometimes you feel like this. If anyone's ever had any GI problem, many times you feel like this. So our goal is for our patients not to feel this way. So now we're going to switch gears, and we're going to open up our game. So just give me a second here to open that up. And Dr. Park is going to explain this game. So we need you to pull out your cell phones, because we want everyone to be an active participant.
Yeah, now it's the real thing. Now you're going to get points. Okay, ready? Okay. In what segment of the colon are colon polyps most likely to be missed? Is it the left colon, the right colon, the middle part of the colon, or the rectosigmoid? So the answer is right colon. That is the correct answer. Right-sided lesions are less likely to be detected because they're usually more flat. Also, depending on the preparation of the colon, the right side is more difficult to prep. than the left side. And so that may play a factor in the fact that most lesions are missed on the right side compared to the left side. Okay?
Do these also correspond to ascending and descending?
Yes, so the right colon would be the ascending, the middle part would be the transverse, and the left colon would be the descending. Exactly. Like the picture that Dr. Parekh showed earlier. All right, next question. So Sayok-san is leading right now. Okay. Followed by Fatih, Joel, Bean, and Deb. What is the lifetime risk of colon cancer? Is it 1%, 4.5%, 10.5%, or 40.3%? Okay, so the correct answer is 4.5%. The lifetime risk of colon cancer in men is 4.7%, so 1 in 21, and 4.4% in women. Okay? All right, so Deb is leading. All right. How common are adenomatous polyps in the general population greater than 50 years of age? How common are polyps in patients greater than 50? 25%, 50%, 99%, or 10%? So the correct answer is 25%. So polyps occur in about 25% of patients that are greater than 50 years of age, and this increases with age. By the late 70s, 50% of patients may have polyps. And if you look at autopsy studies, they suggest an even higher rate, like up to 60% in men and 40% in women by the age of 50. All right, next question. So Deb is still leading. Okay. What are the screening recommendations for patients at average risk of colon cancer at the age of 50? Do you do a colonoscopy every 1 to 2 years? Do you do an FOBT test every 2 years? Do you do a CT colonography every 3 years? Or a flex sig every 5 years? Which one is the most correct answer? Ooh, okay, maybe that was really fast. Yeah. So the correct answer is flex sig every 5 years. Starting at age 50, you need to do a colonoscopy, and if there are no polyps, you get that every 10 years. Yeah, and then an FOBT is like the fecal occult blood test, where you take home the kit and you send it, by mail, and that detects blood in the stool, and you do that annually. It's not every 2 years. You can get a CT colonography every 5 years. It's actually not every 3 years, or a flex sig every 5 years in conjunction with the FOBT test. And these are all what are recommended. All right, next question. Fatih is leading. Okay. Which of the following are not risk factors for colon cancer? Is it obesity, high red meat diet, high fiber, high fruits and vegetable diet, or inflammatory bowel disease? So yes, high fruits and vegetable diet is the one that's not associated with the higher risk of colon cancer. Obesity, high red meat diet, and IBD, they increase your risk. Okay. Oh, Fatih is leading once again. Where is diverticulosis most common? Is it in the left colon, the right colon, the small intestine, or the stomach? Yes, so the correct answer is left colon. That's where diverticulosis is most common. Oh, Deb is leading, 3,983 points. Okay, all right, next. What are the treatment options for patients with diverticulosis? Do you avoid nuts and seeds? Do you take aspirin? antispasmodics and high fiber diet, or do you avoid strenuous exercise? Which one is most correct? So the correct answer is antispasmodics for symptom relief and a high fiber diet to prevent diverticulitis attacks. Deb is leading. Ooh, close with Bean. Okay. What percent of patients with diverticulosis have an acute attack of diverticulitis? Is it 5%, 20%, 80%, or 50%? How many have the attack? Okay, so 20%, so 15 to 25% of patients develop diverticulitis if you have diverticulosis, and 5 to 15% actually develop diverticular bleeding. So 20% is the closest in terms of the range. Ooh, Sharon is leading, 4,603. Okay, yeah. What are potential management options for diverticulitis? What do you do? In diverticulitis, do you give antibiotics? Do you go to surgery to remove the colon? Are there no treatments available? Or can you do both? You could do both A and B, so antibiotics and surgery to remove the colon. Are they both correct? Or is one or the other correct? So yes, most of you got it right. So you can do both. Both antibiotics and surgery are treatment modalities for patients who have recurrent attacks of diverticulitis. And then, as you know, colonoscopy should be performed about 6 to 8 weeks after an attack, after the resolution of the episode. Okay, next question. Sharon is leading at 5,500 points. What percent of patients will need surgery for an episode of diverticulitis? Is it 1%, 25%, 50%, or 15%? Wow, everyone is so good. Okay. So 15% of patients will eventually need surgery, and 85% of patients can actually improve and respond to medical treatment. And that was our last question. Let's see. FS squared 1, followed by Deb and Sharon. Congratulations. Prizes.
Now, we're going to switch gears a little bit and talk about two specific conditions that are one is very common and the other one is not as common, but they get mixed up for each other because their acronyms, or what we call them, are very similar. One is called IBS and one is called inflammatory bowel disease. So let me switch gears here. Okay. Just give me a second, sorry. Now, patients with both irritable bowel syndrome or inflammatory bowel disease, sometimes they do feel like this, and our goal is for our patients not to feel like this. So, irritable bowel syndrome, also known as IBS, has some other terms as well. Some people call it spastic colon. Some people have heard the term nervous colon, irritable colon. Anyone else heard of other terminology for irritable bowel syndrome? Okay. So we do know that about 10 to 20% of the US population is affected by it. So 1 in 5 people are affected by irritable bowel syndrome or some variant of it. It is more common in women than men in the United States. Now, if we look at worldwide populations, it's actually interesting. In India, irritable bowel syndrome is more common in men than in women. In Southeast Asia, it's more common in men as well. So different countries have different gender dominance in irritable bowel syndrome. Normally, patients will present earlier in life with these symptoms. However, we can see it sometimes later on in life. In medical terminology, we call this one of our functional GI disorders, and I'm going to explain what that means in a little bit. But just to kind of explain, how common is it? If we think about diabetes, the prevalence of diabetes is about 3%, heart disease is 8%, and hypertension is 11%. So it puts it in perspective of how common this is. And so this is one of the most common reasons a person may come to see a gastroenterologist is for irritable bowel syndrome. What causes it? This is really where it's tough because we don't have one specific cause. And that's why the management and treatment is very individualized. So what we do know are that patients have an altered GI motility, or what we call gut motility, meaning some people, their gut moves very quickly and they may get diarrhea. Or some people, their gut moves really slowly and they're constipated. Sometimes when it's very slow, they get a lot of bloating. So we do know one of the reasons why you get irritable bowel syndrome is your gut motility is altered. Patients may have an enhanced perception of the normal motility. They feel more pain. So a lot of patients with irritable bowel syndrome present with pain, a lot of lower abdominal pain, cramping. We also know patients with irritable bowel syndrome, a lot of them have a higher prevalence of physical and sexual abuse in their childhood. And so it's our jobs as healthcare providers to kind of, get that out of the history. And can be a delicate matter in getting the history when you're trying to figure out what's going on with the patient. But it is part of our job to figure out what is the underlying cause. So how I like to explain it is there is a neuropathic component because between the brain and the gut, we have thousands of nerve connections, and they share some of the same receptors. And the reason this is important to know is when we talk about treatments for irritable bowel syndrome, one of the treatment classes we use are antidepressants. And it's not to say the patient is depressed, but it's to work on those receptors in the brain as well as in the gut. And I'm going to show you a slide about that. Is what we do know that 5%, there's a distribution of what we call the 5-HT receptors. And in our brain, we have about 5% of them. The other 95% of those receptors in our body reside in our GI tract. So that is why a lot of these antidepressants or some of the neurologic drugs that we give for different conditions also work for irritable bowel syndrome. It's working on modulating that receptor. What are signs and symptoms? So they can be variable. Some people, as I said, may have constipation. Some people may have diarrhea. Some people may get that right after they eat, I gotta go. Like I have to go to the bathroom within 15 minutes of eating. So some people get very fearful to go out to eat, or they have to be close by to a bathroom. Some people present with abdominal pain. It can be generalized. It can be located in one specific area. Sometimes people say eating can precipitate pain. A lot of times though, and part of the definition of irritable bowel syndrome is that the pain will resolve after you have a bowel movement. And so that's one of the hallmark features. Some people have distension, and that goes away after having a bowel movement. Now, some other not so common signs are sometimes patients complain, I have some mucus in my stool or white mucus in my stool. They may have nausea. Patients present with poor libido, or women may say they have a lot of pain during sexual intercourse. Young women often complain that their GI symptoms get worse during their menstrual cycle. A lot of our patients who have irritable bowel syndrome also have fibromyalgia. Fibromyalgia is kind of a muscle pain, nerve type pain that may be followed by a rheumatologist, and some of those same nerve pathways that are affecting your muscles and nerves in your extremities can also be affecting your GI tract. And one of the big hallmark features, and if anyone has ever had IBS or is under the care of a physician who's taking care of you, they may ask, do you have a new stress in your life? Stress is a very big trigger for GI problems, especially irritable bowel syndrome. And so I'll see a patient, they'll be like, at the college campus, we have a lot of young students, and around finals time, we see a prevalence of phone calls. My gut's bothering me, I'm having diarrhea, cramping, and then as soon as finals are over, I feel good. Or I went on vacation, I felt good. Or I had a problem at work, or I had a death in the family. So it correlates with this. So stress is a big trigger for symptoms. Now, clinically or medically, we will define IBS as 4 different variants. So the diarrhea predominant variant, so patients who have predominantly diarrhea as their manifestation, some who are more constipation predominant. Others have this mix. They'll say, well, some days I have diarrhea, other days I'm constipated, it goes back and forth, it's really irritating, I can't plan my life. And then we have the IBS A, where it's alternating, and then the mix. So there's little nuances, not really important what's the major difference between IBS-M and IBS-A. So what should be done? If you are concerned you have IBS, some basic workup that should be done with your healthcare provider are some basic labs, including a blood count, kidney liver function test. Definitely would recommend some stool studies, especially if you've traveled anywhere outside of the country. You want to make sure you don't have a parasite or any other infections. Always very important to get your thyroid checked, because thyroid disease can manifest as GI problems. So some patients who are hypothyroid can present with constipation as their presenting sign. So we always like to check thyroid levels. It is important to be evaluated for celiac disease, which is a true gluten allergy. There are different components where some people, they feel better when they're gluten-free. They could be gluten sensitive, but they don't truly have celiac disease, which is a problem where the villi, the finger-like projections in your small intestine, are flat and they don't absorb certain nutrients and can cause diarrhea or constipation. It is really important to rule out lactose intolerance. More and more we see people who are lactose intolerant. You can do a test, like a special breath test, which is more complicated and insurance doesn't always pay for it. Or a simple test is go off all dairy for 2 weeks and see if you feel better. That's the simple, cheap way to look for lactose intolerance. Now, when is a colonoscopy or endoscopy indicated for workup is if a patient has any alarm signs that we're worried about. So if you see any blood in your stool, if you're anemic, if you have weight loss, those are indications that you should have an endoscopic evaluation to work up your symptoms. And it's our job as the healthcare provider to help guide you on that. But not, if you have a family history of colon cancer in the setting of some new symptoms, I would recommend an endoscopic evaluation. But not everybody with IBS needs endoscopy, but it is indicated in certain situations. We call them the alarm signs: some blood, anemia, weight loss. If they're having severe nausea or difficulty keeping food down, that could be another indication as well. Also, we have to look at the age of onset. So if symptoms are presenting after the age of 50 and you never had them before, endoscopy is indicated. Because as I said earlier on, usually we see this in patients under the age of 35, and it can come and go throughout your life, but usually it presents earlier on in life. Okay. We don't want our patients to feel like Harry Pooper, who hates the bathroom because of their GI problems. So how do we treat IBS? It is, as I call, a multifactorial approach. We have to look at different interventions. We can look at diet, lifestyle, psychological interventions, as we talked about, because stress is a big trigger. There are some herbal therapies that do help, some probiotics, and then we have some medications or Western medications. And sometimes you have to use a combination approach. And we have to look at each patient. And it's what we call shared decision making. So, we have to work with you as a patient to say, what do you want to do? What are you willing to take? What has worked for you in the past? What hasn't? So a stepwise approach, kind of looking at when you have milder symptoms or during your first visit, we may try different diet, lifestyle maneuvers, education, reassurance, making sure there's nothing else going on. If symptoms are more severe, moderate or severe, we may do medications. And, if it's really life altering or really affecting you, we use the combination of using psychiatric help like a psychologist or psychiatrist or antidepressants, because really that combination approach really helps patients. The hardest part is getting people to buy into the, using the psychologist or using the medications with the psychiatrist, because they're like, well, it's all in my gut. Why are you telling me to go see a psychiatrist? But remember, those nerve connections are very, very common, and they're very connected. And you have to remember, a lot of our decisions that we make in life or things that we do comes at a subconscious level. So those nerve connections are activated all the time. Even if we are feeling calm, but maybe we're an internalizer, we internalize all our worry, that may be going to your gut as well. So important to think about that way. So simple things about diet. Now, diet is a very, very complicated topic. We could spend hours and hours talking about different diets for different GI conditions. But I think with IBS, some of the simple things that we recommend are, number one, increase your water intake. Majority of us do not drink enough water, and that's why a lot of us get constipated. If you notice, or if you think about when you travel, you get more constipated when you travel because you're on a plane, you're dehydrated, you're not in your usual routine of exercise and eating healthy. People complain all the time, oh, I got more constipated, I had a bad attack, I don't want to go travel again. So if that's you, you kind of take those proactive measures. Limit caffeine intake because caffeine dehydrates you. If you're a person where diet is affecting you, you may want to avoid or limit the amount of beans and legumes you take in because those can produce more gas. So if you're the person who has a lot of bloating, you want to avoid those bloating type foods. Sugars and sweeteners. This is a really interesting one, is that the artificial sweeteners, so the Splendas, the saccharin, I call them the fake sugars, the ones that come in all the different colors, the blues, the yellows, and pinks. Don't take those. Those are all going to contribute to your symptoms. So if you're taking a lot of those, they can cause diarrhea. They can cause bloating because they're not getting digested. So, limit your intake of those. And then, as we said, lactose is an easy one. Now, fructose is common in a lot of fruits, and you want to be careful with limiting amount because it's that balance, as we talked about, because as Dr. Park mentioned, if you have diverticular disease, we want you to eat a high fiber diet. And so that's where diet gets complicated. So kind of figuring out what works, working with your healthcare provider and dietitian are helpful. Now, there is a diet called the low FODMAP diet. How many of you guys have heard of that diet? How many of you guys have done that diet? Anyone ever try it? It's really hard.
Try it a little bit.
It's hard. It's not easy to do. So essentially, FODMAP stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So essentially, in simple terms, you want to try to avoid the foods that are producing more gas. And these foods are containing a lot of the oligosaccharides, disaccharides, and stuff. So there's the high FODMAP foods and the low FODMAP foods. So if you're having a bad flare-up of your IBS, it is something you can try to do and limit your intake of those foods to help you feel better. It is not a diet that you can do lifelong. It is a hard diet, but something you may want to work with a dietitian and do for a short period of time to see if it helps you. Gluten-free. Gluten-free is a very trendy thing to do right now. Everyone knows about gluten-free. All the Hollywood stars are doing gluten-free. How many of you guys have tried gluten-free in the room here? Or wheat-free, right? And there is something to that. So there are a lot of people who may not truly have celiac disease, but are gluten sensitive. And some of it could be the way the food is produced and the way wheats and gluten-containing foods are produced now. We don't know if that's affecting, because people used to eat wheat hundreds of years ago and we didn't see this degree of GI problems, but it's hard to know. Is it the manufacturing of the food, the processing of the food? So simply you can go gluten-free, wheat-free to see if it's going to help your IBS symptoms. There's no harm in trying. I would also recommend that you do it with a dietitian who understands it, because sometimes what happens is you're like, oh, I'll just go gluten-free. You go to the grocery store and buy all the products that are gluten-free, but you're buying highly processed foods that are not very good for your GI tract. So you want to make sure you understand what it means to be gluten-free and how to make those substitutions so you have a well-balanced diet. But diet does play a big factor into IBS and how you feel. But there are different things you can do. There's the extreme diet of the specific carbohydrate diet, and that's basically like dairy-free, including gluten-free, and some like low FODMAP components. So very hard diet. If you ever look at you're very limited in what you can eat, but it does work in the sense that patients have a lot less bloating. So there are different diets you can do, but just don't do them without some guidance is what I would say, because you can become nutrient deficient if you do. So some of the pharmacologic treatments that we can use for irritable bowel syndrome are antispasmodics. such as dicyclamine, also known as Bentyl. These are the two, and also hyoscyamus. These are the two most commonly prescribed medications for irritable bowel syndrome. If a patient has a lot of diarrhea, we may give loperamide. It's also known as Imodium. Who has Imodium in their bathroom cabinet, right? You can get it at Costco for like 2 cents a pill. That's how cheap it is. And it works. So no harm in using that as well. Diphenoxylate, also known as Lamodal. It's a prescription drug for diarrhea. Other drugs that we're using are one class of drugs, as I talked about, the serotonin receptor antagonist. So by blocking that receptor, you block the nerve pathways from getting activated. There are some chloride channel activators, guanate cyclase C activators. These work for more for patients with constipation. And then as we talked about, different antidepressants. So I'm going to quickly go through some of these, not too much in detail because we have a lot to cover, but we have Elocitron, which we use for the diarrhea variant. It does have some side effects, and 2 to 3 patients out of 1,000 can get ischemic colitis. So it's not commonly used. We use the other loperamides and Lamodals instead, but for those with severe IBS, we can use it who aren't responding to other therapies. There's a drug called Amitiza or lubiprostone, very commonly used in the constipation variant. And what it helps is it activates the chloride channels to bring more water into the colon. It should be taken with food. Obviously, one of the side effects is diarrhea, which is what we want when someone has constipation, but it can also give a lot of gas. One of the newer ones on the market is Linzess, also known as linaclotide. Anyone who watches any bit of TV, they advertise a lot on TV with the little cute commercial girl with the gut going. Works very well as well. So there are different therapy options, but as I think, we always like to think of as like step-up approach in IBS. You try the diet, you try the lifestyle. If that doesn't work, then you try the next level of drugs as well. Some of the antidepressants we can use for more moderate to severe symptoms. Now, when you go on these drugs, you got to give it a try of 4 to 6 weeks. Don't give up after 2 days. These drugs don't work until they've been in your system to 4 to 6 weeks, and we have different ones that we can use. Tricyclics, the SSRIs, and the SRNIs. So I like to look at it as a way of thinking about, so patients who have more bloating, we can use probiotics, diet as a manipulation, and then we have an antibiotic called Xifaxan or rifaximin that is approved for irritable bowel syndrome. One of the herbal therapies that works really well is peppermint oil, or it comes in a marketable formulation which you can buy at the drugstore called IB Guard. Works really, really well, but essentially it's peppermint capsules. For those who have diarrhea, we look at the loperamides. We may use an antibiotic, and then for severe cases, Elocitron. For constipation, for the simple steps, we'll try a fiber supplement such as psyllium. If those don't work, sometimes we'll try osmotic laxatives such as Miralax. Anyone ever buy that? That's over the counter. Ducalax, the stimulant laxatives we can use as well. If those don't work or in combination, we can use the lubiprostone or linaclotide. And then for those who have a lot of pain from their IBS, we can use the peppermint, we can use the antispasmodics and antidepressants. So this is kind of a good guide to use on how should we target your treatment. And everyone is individualized, so that's why there's no magic one for everybody. We have to look at each person's symptoms individually. Okay. So I have about 12 minutes to talk about inflammatory bowel disease, which is IBD. A little bit different. So IBD, what does it stand for? Inflammatory bowel disease. But for those in the business world, IBD also is Investor Business Daily, the journal. So when you Google that, sometimes that comes up over Crohn's and colitis. Okay. Inflammatory bowel disease consists of 2 main diseases, ulcerative colitis and Crohn's disease. Now, there are about 5 to 10% of the patients who have IBD who fit in the middle. They have features of both, so we call it indeterminate colitis. But predominantly, we'll talk about ulcerative colitis and Crohn's disease. Some basic facts. About 1 million to 1.5 million people are affected with IBD in the United States. So we say that's about 0.5 to 1% of the population. So in Orange County, we have about 3 million people who live here. So anywhere between 15,000 to 30,000 people have inflammatory bowel disease. Now, we talked about irritable bowel syndrome saying 20% were affected. So you see the different, the numbers are much higher for IBS. Now, we do know there's what we call a bimodal onset of age. So inflammatory bowel disease commonly occurs in people in their teens, 20s, and 30s. However, we do see a second peak of people getting newly diagnosed with Crohn's and colitis in their 50s, 60s, and 70s. Historically, it's more in the younger people, but now as we are living longer, we are seeing this second peak. We do know that those who have a family history of inflammatory bowel disease have a higher rate of getting this disease. Now, it's not true Mendelian genetics, meaning if your mom has it, you have a 50% chance of getting IBD. It's not that clear. We say if you have a family history, if you are a parent who has IBD, and the chances you'll pass it on to your child is about 1 to 5%. However, there's going to be caveats. Patients who are of Ashkenazi Jewish heritage have a higher rate of getting IBD. And if you see on this map, the areas that are pink and yellow, historically we used to say this was a disease of Northern European populations and northern altitudes. Now, in 2017, in the 21st century, we're seeing this disease all over the world, in places we didn't see this disease 50 years ago. So in India, in Vietnam, in Cambodia, they didn't have IBD 50 years ago. It was always tuberculosis first. So this comes with the thought is, what is one of the causes or etiologies of inflammatory bowel disease? There is something with the environmental component of environments getting cleaner. That hygiene hypothesis of when environments get cleaner and we're cleaner, we're getting more autoimmune conditions. And so as countries become more westernized and cleaner, diets are changing, people are not eating the way they used to, they're eating more fast food, they're eating more processed food, those things could be affecting that. So what causes IBD? We don't know exactly, but we do know there's a genetic predisposition. Over 100 genes have been identified, to be associated with Crohn's or ulcerative colitis. It's not really ready for like prime time where you can go get a genetic test and say, okay, I'm going to get IBD. It's not ready for that yet. It will be there hopefully in the future. We do know what happens is by having a genetic predisposition, something happens to your immune system and basically goes haywire. It doesn't function correctly. Either it's upregulated or downregulated. And the reason is there's some environmental trigger. The environmental triggers that we know of are infections, antibiotic use, diet, smoking, stress, and non-steroidal anti-inflammatories. So a few years ago, there was a study in France that looked at French women who were vegetarian and French women who ate meat. The French women who were vegetarian had a lower rate of getting inflammatory bowel disease compared to those who ate meat. We don't know all the reasons why, but we see these different associations in different studies. Smoking is really interesting. Now, in ulcerative colitis, smoking is actually protective. So what I mean by that is, so sometimes we'll see a patient and, it's kind of odd when they get the disease like in their mid-40s and they're like, oh yeah, I quit smoking. And then 2 years later, I started having diarrhea and rectal bleeding. So for many years, the smoking kept their disease under control. They quit smoking and it flared. Now, we never tell our patients to start smoking. Okay, it's bad for all the other reasons of getting cancer in your lungs. But now in Crohn's, smoking is horrible. It makes your Crohn's disease progress even quicker. So it's very interesting. In these two sister diseases, smoking has a very different effect. Stress is a big trigger, as I said, even for irritable bowel syndrome, as well as for Crohn's and colitis. Infections can trigger off your immune system to kind of go haywire. So a lot of times people say, oh, I went traveling to Mexico or Africa, I got sick, came back, I kind of got better. A few months later, I had recurrent symptoms. I got a colonoscopy and I was diagnosed with Crohn's. So that was the trigger. You were genetically predisposed and that was your triggering event. So you were going to get it, but it's just what causes it. So when we do our histories on talking to our patients, this is what we try to figure out. What was your inciting event? What was the antibiotic? Now, Accutane has been previously was thought maybe there was some association. There have been large studies now since that first study came out debunking that it was a direct cause of causing IBD. However, I would say if I have a patient, I had a patient a couple weeks ago, she is in her 40s. She's had Crohn's disease since her 20s. And then her daughter got acne. She's like, do you think I should give my daughter Accutane? Because, she's genetically predisposed because of family history, and she has a very strong family history. I was like, if you can avoid it, I would. Why do you want to take that chance? It's not a direct association, but there have been, some evidence that could. So we take that very, very carefully. How do we make the diagnosis? We do a history, we do a physical, we do blood test. We do endoscopy, we do a colonoscopy, maybe an endoscopy. Sometimes we need to do radiology studies like a CT scan or MRI. Previously, we used to do a study called a small bowel follow-through where you drink a lot of chalky liquid. They take a bunch of x-rays about every 5 minutes so we can image different parts of your small intestine. Now we use high-tech CTs and MRIs, so it's a little bit quicker, but same kind of concept. So that's how these are the different studies that we will do to make the diagnosis. What's the major difference? Ulcerative colitis only affects your colon. Crohn's disease can affect from your mouth to your anus. So it can affect your mouth, your esophagus, your stomach, your small intestine, as well as your colon. Ulcerative colitis is just limited to the colon. Crohn's, it's what we call a patchy disease. So it can be in skip areas. So you can have one part that looks normal, another area will be inflamed, and then you'll have another normal area. Ulcerative colitis is more contiguous, meaning it starts in the rectum and then goes all the way up through the colon. And some people only have left-sided disease. Some people have disease affecting their whole colon. So it can be different. Some people have what we call extraintestinal manifestations of IBD. They can get eye problems, they can get joint problems, liver problems, kidney stones, and skin conditions of pyoderma or erythema nodosum. So sometimes patients present with these symptoms first, and then we make the diagnosis of Crohn's or ulcerative colitis. So there are other associations. So our goal of our treatment is obviously for our patients to feel better. And so we want them to be in what we call a deep remission. And I'm going to explain that. So I'm going to briefly go over some of the therapies we have. I'm not going to go into in-depth detail because that could take us hours and hours. But it's important to know we use various different medications. And a lot of the drugs we use for both ulcerative colitis and Crohn's, we overlap them. So in this chart, it's showing that we can use the mesalamine drugs. We can use antibiotics. Sometimes we use steroids for people who have more moderate to severe disease. We use immunomodulators. We're modulating your immune system because it's not working so well. We have 3 drugs we can use there: azathioprine, 6-MP, or methotrexate. Then we have the biologic therapies, which are very well known because a lot of them advertise on TV. You can't watch a night of TV without seeing an advertisement for some biologics. So, in ulcerative colitis, we have 4 different biologics we can use. We have infliximab, which is known as Remicade, adalimumab, which is known as Humira, and then we have golimumab, which is known as Simponi. And then those are all in what we call the same class, blocking they're anti-TNF agents. We have another biologic drug that got approved in 2014 called vedolizumab, also known as Entyvio. And so those are the biologics approved for ulcerative colitis. The biologics approved for Crohn's disease are the same 3 that I talked about same 2 that I talked about in anti-TNFs: the adalimumab, the Humira, the Remicade, infliximab, the certolizumab of Cimzia, the vedolizumab, and then the newest one that just got approved was ustekinumab, also known as Stelara. So we have different drugs. And how do we choose which drugs? In simple terms, we look at where is your disease located, how severe is your disease, what are your lab parameters, and then we also look at family history, your age of diagnosis, have you had surgery before, do you have fistulas? So we kind of use different things. This is why the history is really important, as well as the endoscopy and the radiology studies, because that helps us decide what therapy to give. So this is just a picture of the different drugs, and this is showing how vedolizumab or Entyvio is a really interesting drug because it's targeted therapy to the GI tract. So it is only approved and only works in the GI tract. It's not used for other conditions. So the other biologics I talked about, if you listen to those commercials for infliximab or adalimumab, Remicade, and Humira, We use them for psoriasis, rheumatoid arthritis, ankylosing spondylitis. We use them in different conditions, but vedolizumab is targeted therapy. So as we get more and more biologic therapies, we're going to see new targeted therapies. This slide is a really complicated slide showing the immune pathway that is involved in Crohn's and colitis. And then the little smiley faces, or the different boxes that are red, green, and yellow, are showing different drug therapies that have been tested and worked, different drug therapies that were tested and did not work, and then some that are still under study. So one of the newer ones that's really interesting right here is tofacitinib is coming down the pipeline, also known as Xeljanz. It's already approved for rheumatoid arthritis, and it should be getting approved for ulcerative colitis in the next few months by the FDA. So this is why we can't explain exactly what causes inflammatory bowel disease, because all these different pathways are involved. And so we're trying, as we learn more about this condition, we're trying to do more targeted therapy. Sometimes patients do need surgery for ulcerative colitis or Crohn's. Some of the indications for surgery are if they have exsanguinating hemorrhage, so if you're bleeding out, if you have a stricture, and I'm going to explain what that is, if you have an abscess, if a person has perforated their colon or small intestine, that can happen. Sometimes patients are so sick their colon dilates, and it's called toxic megacolon. Some patients need surgery because the medicines just don't work for them. They've tried and tried and tried, and sometimes surgery is the best option for them. I had a patient of mine, a young guy who has gone through every biologic therapy without a response, and he was reluctant to do surgery. He's like, I'll go on any clinical trial, I'll do anything. But he just didn't do it. And finally he went to surgery, and I saw him last week. He's like, oh my God, my life, I haven't had a life like this in 5 years because I didn't realize that surgery was better for me than the medicines. He's like, I got my life back. I can go travel, I can work. And so sometimes surgery is the management. It's not, so we don't look at it as a failure. Sometimes the medicines just don't work and surgery is the right thing. If a patient develops cancer or what we call precancerous cells, then surgery also may be indicated. So a stricture in Crohn's, I always look at it as a blocked pipe. So if your pipe is blocked in your plumbing, what do? We call the plumber, they remove that section, and they put a new pipe. So then it's all open again. Now, in the human body, we can remove the section that's blocked. We can't put a new section in, but then we hook up the healthy tissue to the healthy tissue, so it's a nice new pipe. So in Crohn's disease, it's very common to develop strictures, and at times if that happens, then you may need that little segment of the bowel removed, and we go from there. So sometimes surgery is the right thing for the patient. So in summary, and I kept it very general because this is a lot of stuff to cover, and we can answer some questions, and we'll be here for answers afterwards as well. I would say there's no one size fits all for management of both irritable bowel syndrome as well as inflammatory bowel disease. It is very personalized, and we have to look at each person individually. We have these algorithms and these charts to help guide us and give us guidance, but then we have to look. Something works for one patient may not always work for the other. And I look at it as our goals are, we want you to have a good quality of life. We want you not to be like the patient who's like curled up on the toilet. We want you to be happy. So I think it's important to work with your GI doctor, work with your primary care doctor, work with your whole healthcare team so you can feel like this when you go to the bathroom, not like the other guy. So I will end my talk here. I want to thank you all for your attention, and then Dr. Park and I will field some questions for a few minutes, and then we'll be up here afterwards as well. Do we have any questions?
You're using antibiotics in both diseases. Is there a specific microorganism associated with either of the diseases?
That is a very good question. So I'm going to repeat the question. He asked, sometimes we do use antibiotics for treatment in irritable bowel syndrome as well as inflammatory bowel disease. And he asked if we are targeting a specific organism. So we are not targeting a specific organism because we know as we're learning more about the gut microbiome, it is a very complex environment in our gut. We have millions to billions of bacteria, and many of them have not been have been typed. So we do know there are certain species that do become more predominant in inflammatory bowel disease as well as irritable bowel syndrome. There have been researchers who are doing what we call microbiome analysis of the stool to say, okay, well, these bacteria are more predominant and these are not, so maybe certain antibiotics may be useful for you. We haven't gotten to the point where we can do the personalization of the antibiotics or even of a probiotic. Like, can you take a specific probiotic to make these bacteria grow better and decrease the growth of these? So we haven't got to that, but I think as we learn more about the gut microbiome, we will head that way. The antibiotics that we commonly use in irritable bowel syndrome, xifaxan or rifaximin, is used commonly in traveler's diarrhea. So it can work to treat various different bacterial infections, and it also works on these other gut organisms in decreasing their growth. So, okay, question right there. Okay, so the question was about giving foreign fecal matter to a person or to a patient to try to control some of these GI conditions. I'm gonna have Dr. Park talk about that. So it's also known as fecal transplant.
Yeah, so fecal transplant, currently we're using it mainly for patients who've been affected with C. difficile colitis or an infection from the bug C. difficile. And so the idea is that if you put somebody's healthy donor stool into someone with a diseased colon with this bad bacteria, and you replace it with this good bacteria from the donor, that it replaces the bad bacteria and then makes the person healthy again. So we use it currently in patients who've been affected with recurrent C. diff colitis, refractory to multiple antibiotics. Do you?
I understand that treatment you just mentioned is only approved for C. diff. So would you see the day where you'll be able to use it more widespread for somebody with colitis?
Perhaps, but I think the issue is that we currently don't know what's going to happen in the future, like 20, 30 years down the road. Like, you know, we do screen all the stool, and there's an open biome bank that we use, for example, where they take donors who are healthy and they donate to a repository or a bank. But, you know, you have to know, like 20, 30 years down the line, what are the, how would you say it? What are the future consequences of getting someone else's donor stool? Are there diseases that maybe we don't know about that we don't think of screening for that later come out that would be, and so there is actually a study where people are tracking what happens to the patients that get this FMT.
Right.
And I think you're doing one
Right.
of the
So,
studies.
right. So there are a lot of studies going on in different GI conditions by using fecal transplant, but they're only under study. So they are looking at Crohn's disease. They are looking at ulcerative colitis. Preliminary data showed maybe some improvement in ulcerative colitis, but it was very early. And you have to remember, ulcerative colitis and Crohn's disease, it's a lifelong disease. And when they do these studies, they're only looking at outcomes in the study 4 weeks after you got it. So they still need to track what happens 1 year, 2 years, 3 years down the line. So they are looking, and there's a lot of new research in the gut microbiome. It is one of like the hottest topics for NIH and our national societies. Even with recurrent C. difficile, it's still under research. It is one of the only approved conditions. However, at many institutions, including ours, it's a research protocol still for us to do the fecal transplant. It is not like standard therapy where you can just say, hey, I want to order some stool and give it to myself. Now, you can watch a YouTube video and you can learn how people do it. You will hear stories of people giving themselves fecal transplant. You will hear of stories or special clinics where you can pay lots of money to get fecal transplant and it's going to cure you. But we don't know what are the long-term consequences. Can you develop another autoimmune condition 5 years after you got fecal transplant? That's where the research is going. Our National Society, the American Gastroenterology Association, is doing a 10-year study of different places that are giving fecal transplant for recurrent C. diff, and they want to see what happens to these patients over the next 10 years because we just don't know yet. But it is an interesting topic as we learn more about the gut microbiome as well on that end. Question?
Yeah, two things that you didn't mention at all that I've been dealing with is digestive enzymes, not at all mentioned in there for people with IBS. And the other one would be the Candida albicans or similar overgrowth of that type of thing, not a bacteria, different.
Right. So the digestive enzymes and the candida don't have as much evidence in Western medicine literature. It is more in the naturopathic literature where they're using those treatments. We don't have enough. I don't have personally have enough experience with it. Usually, those things are done either with a dietitian, and usually when we use digestive enzymes in the GI tract, it's when someone's pancreas is not effectively working. And if you have a pancreas problem, then you need additional digestive enzymes to help you absorb your nutrients. So not everyone with irritable bowel syndrome has a pancreas problem, but it's looking at that. The candida concept kind of goes along with the whole gut microbiome or the dysbiosis of the gut microbiome, but we're still learning more about it. I think the naturopathic doctors have more experience with that and using different diets and foods, and they use different therapies to manipulate that. Okay, right here.
What are the gut ramifications in a patient with scleroderma, and what do you do for treatment, if anything, for those?
Okay. So her question, very good question, is asking a very specific topic of if a patient has scleroderma, which is a condition, a rheumatologic condition, and how it affects the GI tract. And it does affect the patients as they progress with their scleroderma. Unfortunately, they do get complications in their GI tract. And a lot of it is what we call motility disturbances. So it can start from the esophagus all the way down to the colon, and it can affect how you swallow your food, and patients sometimes have difficulty with swallowing their food. Usually it's where we see more of a slowness of the motility. And so things don't move as quickly through the system. And so sometimes we have to enhance it with different stimulant laxatives or manipulations with smaller meals. We don't have the best treatments for altering the gut motility in this time right now, but it does affect the gut motility. Sometimes patients can get telangiectasias, which can periodically slowly ooze blood. So periodically, if it's a severe form where patients become hospitalized from the anemia that it's causing, we can do endoscopic therapy, and we can what we call buzz them with electrocautery and try to decrease the amount of them. Okay, I think we have time for one more question. Okay, two more questions right here.
Have they done studies between different societies to understand whether some of the things going on in the Western diet, things happening here, are behind some of these systems compared to societies, local, regional things in out-of-the-way areas, whether it's Italy,
Yes.
some places, Peru,
Yes.
you know, because we have something like today 80 million people in the country here, adults, who are on 5 or more medications. And we have obviously a large increase in
Right.
obesity, a very large increase in the amount of food consumed that's prepared outside and
Outside the home. Right. So there are a lot of studies looking at that. I think at overall health and how it affects different diets, how it affects. And I think that's where the whole concept of the Mediterranean diet came in, because they looked at, Mediterranean populations had lower rates of heart disease. And so that's where that concept of the Mediterranean diet came in. And then now the concept of the paleo diet, really going back to how people used to eat. And if you really look at what's in the paleo diet, is you're avoiding all the processed food. So you're trying to avoid all the foods that are handy and very convenient. So the foods that come in boxes and bags are the things that are very detrimental to our health. Because in the paleo diet, you're basically cutting those things out. You're eating some grains, not that much. You're eating fruits, vegetables, limited amount of dairy, and then meats and fish. And so if you think, they are doing those studies and they are looking at that. And really the big concept of is getting rid of processed food. And, you know, some people are putting the fact of like, okay, eat less sugar. Why should we eat less sugar? Is because all the processed food, if you look at it, the second or third ingredient is some form of sugar, high fructose corn syrup, you know, and also they're looking at how food is manufactured and processed in the United States, as well as other countries too. So they are looking at that stuff and its overall effects.
One more question.
Okay, we'll have one more question. Yes, absolutely. So you can have, and it can vary sometimes, and then it can change. Later on, it can become more of the diarrhea variant or the bloating variant. So her question was, can you have a variant of irritable bowel syndrome where it's just bloating and cramping? Yes, you can. And it's also important to rule out, in that case, something called small bowel bacterial overgrowth, which is like the dysbiosis of the bacteria. And that's where that can easily be done with a simple breath test that we can do. All right.
Drs. Parekh and Dr. Park, this was a wonderful presentation. We hope you come back. And
Thank you
please
for having
visit
us.
with the doctors after. Thank you.
Thank you very much for having us.